We will get started in just 1 or 2 minutes. We do have 250 registrants and about 100 people on the webinar at the moment. So stay tuned. We'll start very shortly. Good morning, everyone, and thank you for attending this webinar of the HSCRC Rate Year 2018 Quality Program Update. Please note that this webinar is being recorded, and with that, we'll advance to the next slide. So we'll review the housekeeping details very quickly. Each attendee is muted during the course of the webinar. We will take questions incrementally if we have time. Otherwise, there is a several-minute Q&A session at the end of this session. Questions can be asked through audio, where we will unmute you, and you can raise your hand to do that, or you can type your questions into the webinar questions area. So the agenda will include a review of the Maryland all-payer model that we're currently under, a quick review of the performance-based payment programs, and then we'll get into more detail on each one of those programs. And those include our quality-based reimbursement, Maryland Health Care Associated hospital-acquired conditions, sorry about that, readmission reduction incentive program, our potentially avoidable utilization savings program, and then we'll finish up with 2 items on revenue at risk for the quality programs, and then we'll talk about reports to track the hospitals get to track their own progress, and then of course I mentioned the Q&A session. So we just did the housekeeping, so we'll advance to the technical agenda. So in terms of the all-payer model overview, the all-payer model began in January of 2014 with the approval by CMS and the Centers for Medicare and Medicaid Innovation of an application that Maryland submitted, such that we could switch from a test that looked at our per inpatient admission hospital payment to a new test that includes all payer per capita, total hospital payment, and quality. Key provisions of this agreement include we are not automatically exempt from the QBR program, from the CMS value-based purchasing program. We need to seek an exemption each year as a condition of this model. For the MHAC program, we must reduce complications by 30% as measured at the end of 2018. For our readmission reduction program, we must reduce Maryland Medicare readmissions to be at or below the national rate by 2018. And in terms of potentially avoidable utilization, that program's in place to help us meet our growth ceiling in terms of costs to keep under 3.58% a year, and then we must achieve a savings to the Medicare program of $330 million at the end of the 5-year model period, which of course is from 2014 to 2018. And then the last requirement of this model agreement is to meet or exceed.
I'm just pausing because we're getting comments. The sound is not good and the speaker keeps going in and out. And you need to be using the telephone line, not your computer. So I suggest you call in. I'm not sure if that could be the issue. No, it looks like you are, Neil. We will we'll continue to work on the audio. Are other people able to hear us? All right, so we've gotten some confirmations that yes, we're just moving the speakers around. We appreciate it. All right, great, thank you. A couple of people have responded that they can hear us, so
okay.
Awesome. Apologies, I just want to make sure. Great.
Right. So to round up this model agreement requirements, we have to meet or exceed CMS's amount of revenue at risk allocated for performance-based payment programs. So here's a structural diagram. We see that HSCRC Commission and staff work certainly very closely with DHMH. We do both have an advisory council, and then as we look down the diagram under the HSCRC, we see the nice purple boxes. That's the performance measurement work group, and that's where the work of updating and monitoring the payment programs related to performance is done. So in terms of the programs, I just wanted to show you a picture of our quality-based payment programs in purple, and in the light red, you see the CMS national programs. And our programs are roughly equivalent or intended to meet the CMS requirements. Our performance measurement work group, it did commence its work at the kickoff of the new model, but we've had a performance measurement work group in some form for the last 8 years since I've been at the Commission. We have a broad stakeholder participant group. We meet monthly. All the meetings are open to the public, either by webinar or in person. We do review and recommend the guiding principles of our programs. The work group looks at the annual updates that need to be done for the payment programs. And then we also consider what strategic direction for the future where we need to be headed. And you see the list of issues, and that includes at this time we're thinking about high needs patients, chronic conditions, care coordination, population health, et cetera. So the guiding principles I mentioned, the current guiding principles that on which we achieve consensus are that we must improve care for all patients regardless of who their payer is, including if they're self-pay, that the incentives should support achievement of all the payer model targets that I mentioned. The program should prioritize high volume, high cost issues, the opportunity for improvement, the most improvement in the area is certainly of national focus. We should have predetermined targets and predetermined financial impact in our programs. The hospital needs the ability to track their progress, and Allison will discuss that later in the presentation. And we need to encourage cooperation and sharing of best practices among hospitals. And we need to branch out and not just stay within hospital four walls and consider all settings of care. I forgot to mention, this is Diane Feeney, and I work on the quality programs. My colleagues Allison Schuster and Laura Mandel will do sections of this presentation. So I'll now continue and talk about the quality-based reimbursement program for rate year 18. The QBR program, on the left side of this slide, you see the measures and you see the things that are new for rate year 18 that are used for payment. We see there's an addition of the care transition CTM3 measure to HCAHPS. We've added a couple of infection measures, MRSA and Clostridium difficile, and we also have suspended the ARC Patient Safety Indicator 90 just because of some technical issues with base and performance data not being compatible. You'll see on the right side of the slide Maryland's programs and their relative weights in calculating hospital scores compared to the CMS value-based purchasing domains and how they are weighted. And just a quick fact, our programs did begin a full 3 years before the CMS value-based purchasing program went live. So HSCRC, in terms of the methodology, inclusion rules, and data sources, we'll just talk about those technical issues. We will use data submitted to CMS for the IQR, or Inpatient Quality Reporting Program. The exception of this is PSI 90 because we look at that for all payers, and for our mortality measure because we need to use HSCRC case mix data for that. We use the CMS rules when possible, and hospitals must have scores in 2 of the 3 domains to be included in the QBR program. For hospitals with measures that have no data, attainment only is used, and we'll talk about the program being the better of attainment or improvement very shortly. For hospitals that have measures with data missing for the base and performance periods, you may receive scores of 0, and so it is imperative that you review your data as soon as it's available from CMS and be in touch with HSCRC with any technical issues beyond your control. So here we see a table of the minimum numbers for inclusion for the 3 domains in the QBR program and the data sources. So again, I mentioned that the points are given for the better of attainment or improvement. Attainment compares hospital rates to a threshold, a pre-established threshold and benchmark. And again, we use the CMS values for that. If your score, to get the most amount of points, which are 10 for each measure, you have to be at or above the benchmark. And if you're at or above the threshold, you'll get a point between 1 and 9. And then if you're below the threshold, you would get 0. For improvement, this compares hospital rates to the base, to your own base year performance. And the highest you can get for improvement is 9 points. So this is just a picture of showing the attainment versus improvement concept. This example shows both attainment and improvement on the immunization 2 measure. The hospital in this scenario would get 5 points, but theoretically one might get 10 on one and 8 on another, and in which case HSCRC would use the higher of that, which is similar to what CMS does. Here we have the performance period timeline. It shows you the base and performance periods for in terms of rate year and calendar year quarters, and there are different periods for different domains of measures. So we wanted to show that in a picture for you. Here we, in order to determine the financial impact, we have a preset scale, which is, we use the base period QBR scores to determine hospital rewards and penalties. And if you score below the target, you'll receive a penalty, and those that are above receive a reward. So the final score for QBR, for example, if you get a 0.8, you will get minus the full penalty of the program, which is minus 2% in revenue. If you score at 0.54 or above, you will get a 1% reward, which is the maximum reward one can get for the program. And this program is not revenue neutral, so if everyone scores in the reward zone, everyone gets a reward if they fall within these within these scoring strata. So let me just do the updates recap that were approved for rate year 18. The clinical care process subdomain was removed. This PCO1, which is early elective delivery or C-section, has been moved to the clinical care from the clinical care domain to safety. The AMI and immunization process measures are removed. The CTM3 is new, and then the two issues that were addressed by the commission and approved 2% of revenue at risk for the program and the weighting of each of the domains, which we discussed earlier. So with that, that completes the section of the presentation on the QBR program. And I'll hand off to Allison Schuster for the next section.
Great. Thank you, Diane. So my name is Allison Schuster. I'm the Associate Director for Performance Measurement, and today I'm going to give a brief overview on the rate year 2018 Maryland Hospital Acquired Conditions Program. So the MHAC program uses a list of 65 potentially preventable complications that was developed by 3M. Although, as you'll see later, we do not use all 65 PPCs in rate year 2018. The PPCs are post-admission or in-hospital complications that may result from care and treatment rather than the underlying progression of disease. And examples of these potentially preventable complications are accidental punctures during an invasive procedure or hospital-acquired pneumonia. In order to code the PPCs, the logic uses the present on admission indicators that are submitted for each of the 30 diagnosis codes that are in the case mix data. And then the MHAC program links hospital payment to hospital performance by comparing the observed number of PPCs at each hospital to the expected numbers at that hospital. So for rate year 18, the base period is fiscal year 2015, and that is run under version 32 of the PPC grouper, which is ICD-9 compatible. The performance period is run actually under version 33, and the performance period is calendar year 2016. And version 33 of the grouper is designed to be ICD-10 compatible, but it is designed to mirror the version 32 of the PPC logic. That is, version 33 does not yet incorporate the additional specificity that ICD-10 will allow. Despite 3M's efforts to make these two versions compatible, the HSCRC does have a contractor who will be monitoring whether there are impacts related to the ICD-10 transition for the MHAC and other performance-based programs. Also, the HSCRC is still working through applying whether we can apply some clinical logic changes that 3M has recommended that they will be implementing in version 34, whether we can implement them outside of the grouper for rate year 18. However, I want to caution people that it is much more difficult and the clinical logic is very complex, such that it is difficult to make many of these changes outside of the grouper. And the PPCs that are in rate year 18 at this time will be the PPCs. We aren't going to be removing any new PPCs, and we won't be changing tiers. Those are things that we will consider annually as we make updates to the program. So next, I'm going to walk through the scoring methodology. And the current MHAC scoring methodology was first implemented in rate year 2016. and it hasn't changed significantly, but as I go through the presentation, I will point out where there are rate year 18 differences. So for the MHAC program, hospital performance is measured using the observed to expected ratio for each PPC. In order to calculate what the expected numbers are, we calculate normative values using the fiscal year 15 base period data. These normative values are just the percent of patients statewide within each APR, DRG, and severity of illness level that have had each type of complication. We then multiply that percent by each hospital's number of discharges in each of the diagnosis and severity of illness categories to get that hospital's expected PPC rate. For people who would like additional information, we do provide examples of how expected values are calculated in the MHAC memo in the appendices. This blue box at the bottom, I just want to point out where we're providing this information. For the MHAC program, unlike other programs, we have a single Excel workbook that we distribute at the baseline of the program as well as monthly. And I just want to point out that those normative values that are used to calculate the expected numbers are included in that workbook. So they're not posted separately, we've just embedded them, and that would be where you would go if you needed those values. So for rate year 16, there are only actually 63 PPCs that are available. PPC 24 was suspended by 3M due to clinical validity issues, and we did that for rate year 17 as well. But also under ICD-10, PPC 43 is combined with PPC 42 due to issues with separating these two complications under ICD-10. So we've gone ahead and made that combination also under the base period data that was run under 9. In addition, starting in rate year 17, we developed combination PPCs. And in rate year 18, we added 3 additional clinically related combinations. So combo 1 was sort of the rate year 17 general combination. And the reason we did this, these were PPCs that generally had very low rates. So we combined them to increase sort of the validity and reliability of the measure. The combos 2, 3, and 4 are these new clinically related complications. And under the methodology, these combinations are scored as if they are one PPC. In addition, for rate year 18, we have moved 5 PPCs that had lower reliability into a monitoring-only status, and thus these will not be scored for payment purposes. However, we do still provide in the MHAC workbook both the individual data on both the individual PPCs that comprise the combinations as well as those that are in monitoring-only status so that hospitals can track those as well. So this slide shows the adjustments or exclusions that are applied to improve the measurement fairness and stability. So for the fiscal year 15 base period, at the statewide level, we remove any APR, DRG, and severity of illness cells that have less than 2 cases. We also remove any palliative care cases, which are identified using ICD codes, and we remove what we're kind of called catastrophic cases. Those are cases with 6 or more PPCs. And the palliative care and the 6 or more PPC exclusions are applied for both the base and the performance period. In addition, for each hospital, there are some specific PPCs excluded. That is those where the number of cases at risk is less than 10 or where the number of expected cases is less. And this is done in the base period only. And what it means is that for each hospital, they are not necessarily measured on all PPCs. And a list of what PPCs are excluded for each hospital are provided in the MHAC workbook. I'd also like to point out, for anybody who has programmed the MHAC logic, that in rate year 18 there were some changes in when these exclusions were applied, and the normative values were recalculated after these exclusions. So next I'm going to talk about how we score hospital performance for each PPC. This is very similar to what Diane has just reviewed that is used for the Maryland QBR program and the Medicare VBP program. Essentially, the methodology uses benchmarks and thresholds to assign 0 to 10 points to hospitals for each PPC or each PPC combo. These thresholds and benchmarks are calculated using the base period data. For serious reportable events, we have actually set the threshold and benchmark at 0, and the 5 serious reportable events are presented here. These were determined in collaboration with the Performance Measurement Workgroup and stakeholders and haven't changed since fiscal year 16. For all other PPCs, we calculate the threshold as the weighted mean of all the OE ratios. So that really means it's the statewide average of 1. However, the benchmark used to be the weighted mean of the top quartile of OE ratios. However, starting in rate year 18, due to concerns that small hospitals were dominating the benchmarks, the HSCRC changed the benchmark to be the weighted mean of the observed to expected ratios for top performing hospitals that account for a minimum of 25% of statewide discharges. This means for each PPC, a different number of hospitals is used to set the benchmark, but always that benchmark has at least 25% of all discharges in the state. Thus, small hospitals, for example, are less likely to be dominating the benchmark. So once you know the threshold and benchmark, you can calculate attainment and improvement points. This is done by comparing the OE ratio to see whether it is higher than lower than the threshold and benchmark for attainment, or whether it is higher or lower than the previous year's performance for improvement. Again, for each PPC, the points range from 0 to 10, and as with the QBR program, the final points are based on the higher of attainment or improvement. Okay. So the MHAC methodology weights PPCs differently so that more emphasis can be put on some target PPCs. This is consistent with the guiding principles Diane outlined earlier. What is new is for rate year 18, we have moved from having 3 tiers to having only 2 tiers. So tier 1, which is weighted at 100%, are the high volume, high cost PPCs, or ones where we believe there is opportunity for improvement, or ones that are of national focus. Tier 2, which is weighted at 50%, are all the other PPCs, and these are ones that may be low volume, have less reliability, may not affect all hospitals, and also include the obstetric PPCs. This slide tells us just briefly how we calculate the overall MHAC score for each hospital. And again, in the MHAC workbook, we do provide how hospitals perform on each PPC, that is the number of points scored, and each hospital overall's MHAC score. Now that you know the score, I'm just going to review how you determine the financial impact of that score. So for the MHAC program, there are actually 2 preset payment scales. In which scale is used depends on whether the state as a whole hits a minimum improvement target. For rate year 18, that target is 6%. And I'll show you this again on the next slide. But I just also want to point out, unlike the earlier MHAC program, the revenue adjustments for the MHAC program are now not revenue neutral, meaning rewards are not limited to penalties collected, and all hospitals can receive rewards. This is different than some of the national programs that simply penalize the lower quartile and reward the top quartile, and it is designed to encourage cooperation and sharing of best practices. So this slide just illustrates the two-scale concept. The final two scales, the final payment scale, are in the MHAC Excel workbook. But the scale on the left just shows if we do not hit as a state the minimum improvement target of 6%, we will have a target where up to a max of 3% of penalties can be applied, and there are no rewards. If the state exceeds that quality target, however, the penalties are reduced to a max of 1%. We have a revenue neutral range where some hospitals will have neither a penalty or reward, and hospitals that score high will be subject to up to a 1% reward. Payment adjustments will vary on how the state does, but are fixed for each score, and you can track how hospitals are doing on the overall statewide improvement in the MHAC workbook. So last, I just want to briefly highlight that the HSCRC does contract with an independent auditor to do a coding audit of 10 hospitals annually. And the purpose is to identify potentially systematic errors in coding practices within a facility. When we do audits, we audit 230 cases. 50% of them are a random sample for the ICD audit, but 50% are specific for a POA audit. And for that 50%, we target cases, for instance, that may have had a change from preliminary to final data, or where we believe a PPC would be triggered if a certain diagnosis wasn't present on admission. Hospitals that exceed the 5% benchmark for present on admission quality may be required to do a second independent audit or may be subject to financial penalties. And this last slide, again, is just a recap of the measurement changes and the changes for rate year 18. Again, the methodology has not changed significantly from the fiscal year 16 policy or the rate year 16 policy, but you can see the changes that we've made below, and that is, again, moving to 2 tiers. We've made some combinations and moved some PPCs out of the program. We've changed how we calculate the benchmark, and we've updated when the exclusions are applied and the norms are calculated. My final slide is I just want to show the progress that hospitals have been making on reducing complications. I would like to also applaud all hospitals for their significant reductions and improvement in patient care in Maryland. Comparing calendar year 13 to calendar year 15, there has been a 33% reduction in the all-payer case mix adjusted complication rate. And this actually meets the 30% reduction goal that has been laid out in our waiver. That goal was a goal we had to achieve by 2018. We have already achieved it, although we will need to maintain it through 2018. But also, Maryland will continue to expect continuous quality improvement. That is, we're not going to be stopping at 30%. And with that, I would conclude the section on the Maryland Hospital Acquired Conditions Program and turn the presentation over to my colleague to walk through the Readmissions Reduction Incentive Program.
Hi, this is Laura. I'm going to be talking about the Readmission Reduction Incentive Program, RRIP. And the program is a payment program designed to support the waiver goal of reducing inpatient Medicare readmissions, but in Maryland, we apply it to all payers. And the program was approved in 2014 and began to impact hospital revenue starting in rate year 2016. And just as a reminder, the model agreement requires Maryland to lower readmission rates to the national level by the end of the demonstration period and to make annual progress each year by reducing the gap by 1/5. I'm going to go through the methodology quickly for the readmission program. So we use a case mix adjusted inpatient readmission rate, and the criteria for this has not changed for rate year 18. It's still 30-day, all payer, all cause, all hospital readmissions. We do have some exclusions, and there are some changes for rate year 18, which are indicated by the red. We exclude same day as well as next day transfers, rehab hospitals. We're suspending oncology discharges. We exclude planned readmissions, which are assigned based on the CMS planned admission, and we just updated to the version 4 for rate year 18. We also include in planned readmissions all deliveries and all rehab discharges, as well as deaths. And just as a quick note, in the table below, you can see that based on this exclusion methodology update, actually the way that we calculate the base year rates also changes, and you can see that using the different methodology for the different years actually changes what the base period looks like. So for the data sources and timeline, the data that we use, as I mentioned, is the inpatient abstract or case mix data with the addition of the CRISP EID, which is a unique identifier that allows us to track patients across settings. I also want to note here that we are currently case mix adjusting using discharge APR-DRG and severity of illness levels, as Allison mentioned, in version 32 of the APR-DRG grouper for base period, for our base period for this, which is calendar year 2013, and our performance period is calendar year 2016, which is run using version 33 of the grouper. In terms of time frames, I'm showing here the example for the calendar year 2013 base period. For this time period, we would use all discharges between January 1st and December 31st, plus an extra 30 days until January 2014 to look for readmissions within 30 days of any December 2013 discharge. On a monthly basis, we would, for example, take all January discharges and then look for readmissions in January and 30 days into the subsequent month. Because of this lag in data for the 30-day follow-up, the monthly data you will get will be 1 month farther back than the MHAC data that doesn't require this extra 30 days of data. For the case mix adjustment, this is very similar to the MHAC case mix, so I'm not going to go through it, but I did want to mention that the bottom bullet here, HSCRC and stakeholders did evaluate alternative risk adjustment methodologies, but we'll continue with the existing case mix adjustment for rate year 2018. Our existing case mix adjustment was found based on stakeholder input to be more than adequate for right now, and so we're going to continue looking at other things, but it works pretty well for right now. The big change for rate year 18 for the readmission program is that the readmission program was modified to link payment to hospital performance as measured by the better of attainment or improvement, and this is a change when it was just previously measured just based on improvement. And so this was due to concerns about hospitals with low readmission rates having less opportunity for improvement. So the adjustments for the readmissions program are scaled with maximum penalties up to 2% of inpatient revenue and maximum rewards up to 1% of inpatient revenue. And as you can see below, this is for rate year 18, but we're actually also applying it retroactively to rate year 17. And you can see the improvement targets and attainment benchmarks below. For the improvement scaling, so hospitals, we calculate both their improvement and their attainment scores. So for the improvement part of it, it compares calendar year 16 case mix adjusted inpatient readmission rates to calendar year 13 readmission rates. And the improvement target for calendar year 16 is a 9.5% decrease. Again, the adjustments are ranging from the 1% reward to the 2% penalty. And hospitals with the readmission rate reductions of 20% or more receive a 1% reward. Hospitals with a readmission rate increase of 10% or more will receive a 2% penalty. Hospitals between those two amounts will receive scaled adjustments between the 1% reward and 2% penalty. For the attainment scale, it compares calendar year 16 case mix adjusted inpatient readmission rates to a state benchmark. I also wanted to note here that we adjusted attainment scores to account for readmissions occurring in non-Maryland hospitals for Medicare data in order to be able to calculate attainment scores using Medicare data, I apologize. And the attainment benchmark for calendar year 16 is 11.85%. And again, it's the 1% reward to 2% penalty range. Hospitals with readmission rates of 10.61% or less, which is equivalent to the highest performing 25th percentile of hospitals, receive the 1% reward. Hospitals with readmission rates of 14.16% or greater will receive a 2% penalty, and those that fall between those two rates will receive the scaled adjustment. And again, I'm saying the word will, but it's may, depending on which one is the better score for your hospital, which I will walk through right now. So as you can see in Hospital A, which we've indicated with the yellow, their case mix adjusted rate for calendar year 13 was 16%, and they were able to reduce that to 13.5% for calendar year 16, which is a change, a reduction of 15%. So as you can see on the improvement payment scale, the negative 15% rate change is equivalent to a 0.52% adjustment. If you calculate their attainment score, however, because their 13.57% is so much higher than the 11.85%, that would be calculated as negative 1.49%. So for this hospital, Hospital A, we would choose the improvement score for their final score, so which would be the 0.52%. For Hospital B, which is in the green, their calendar year 13 score was rate was 10.33%. They actually increased by 5% in calendar year 16 for 10.85%. So you can see in the improvement scale, this 5% change increase is equivalent to negative 1.49% payment adjustment. However, because their 10.85 is still lower than the 11.85%, they actually, based on the attainment scale, get a positive adjustment of 0.81%, which is higher than their improvement score. So their final would be 0.81%. So just to go over the changes that I recapped, the major change for 18 is that we're linking payment to hospital performance by the better of attainment or improvement. Again, this also applies retroactively to rate year 17. And here are some of the other measurement changes that we went through as well, including updating the transfer definition, suspending oncology discharges, updating to the latest CMS planned admission logic, defining all rehab discharges as planned and ineligible for readmission. And we also just wanted to touch base a little bit on our progress for readmissions. And as you can see, Maryland hospitals have made some great progress in reducing readmissions. And as you can see in the graph, which is under the rate year 17 methodology, there has been a decline each year in the readmission rates. In calendar year 15 compared to calendar year 13, there has been a 7.15% reduction in the all-payer case mix adjusted readmission rate. And again, as Allison said, we want to applaud the hospital's continued efforts in reducing readmissions. I'm going to send it back over to Allison.
Thank you, Laura. So next, I'm going to be reviewing the rate year 17 potentially avoidable utilization savings policy. And this is a policy that prospectively impacts rates and prospectively impacted rates starting this last July. I guess we're still in July this month. So just as some background, the POW savings policy builds on previous commission policies that were implemented in order for us to maintain our exemption from the CMS Readmission Reduction Program by ensuring that there would be savings to purchasers. Last year, the Commission continued the focus the policy on readmissions due to concerns over slower reductions. However, new in rate year 17, the policies changed to focus more broadly on the percent of revenue associated with POW, potentially avoidable utilization. And this is partially because we are in the third year of the model. We've been making investments GBR investments to help hospitals work on care coordination, and at this point we are expecting further reductions and potentially avoidable utilization. In the first few years of the model, we knew that it would take time for those reductions to take effect. So in rate year 17, the POW definition includes readmissions, but we've also added the ambulatory care sensitive conditions as measured by the Agency for Healthcare Research and Quality's Prevention Quality Indicators, or PQIs. I just want to note here that our current POW methodology actually no longer contains the estimated cost of PPCs. So it is just readmissions and it is just PQIs, although as I'll mention, we will be looking to expand our POW definition. The reasons we've included PQIs, they do account for 4% of revenue. There's been less progress in reducing PQIs as compared to readmissions, and CMS will be moving to use PQIs for physician payment, and this is a way to align with what they're doing. Now, other changes to the POW definition are that we are now aligning it with the market shift adjustments. This means that we are including observation stays that are 23 hours or longer, greater than 23 hours, excuse me, and we will be measuring readmissions at the receiving hospital. This is different than the Readmission Reduction Incentive Program. For the POW Savings Program, we look at readmission costs that are included at the receiving hospital. And this is more consistent with the idea that savings for a hospital will only be achieved if they reduce readmissions that occur at their own hospital, and continues to push hospitals to work together to reduce readmissions in the communities that they serve. So this slide just outlines the rate year 17 POW savings reduction. And this savings reduction was increased because now that we are in the third year of the model, we believe that there needs to be an increased savings from reducing POW. So the annual value of the POW savings amount for rate year 18, or fiscal year, rate year 17, was increased from 0.2% to 0.45%, resulting in a statewide POW savings adjustment of 1.25% of total hospital revenue. Because last year's statewide savings reduction of 0.6% was added back into rates, this represents an incremental reduction of 0.65%. Now, every hospital's contribution to the POW savings, you can see, is the percent POW revenue you have at your hospital times the required reduction in POWs to achieve the statewide savings of 1.25%. What this really means is that the hospital contributions to the overall statewide savings is adjusted based upon their percent POW in the beginning. So if you have higher POW, you will have higher prospective adjustments. If your potentially avoidable utilization is lower, your hospital will have lower adjustments. The POW savings are also capped at the statewide average reduction for hospitals with higher socioeconomic burden using the percent Medicaid and self-pay/charity inpatient utilization. In addition, the additional two recommendations that were part of this year's policy that was approved by the Commission were that we need to evaluate further expansion of POW definitions for rate year 18 to incorporate additional categories of unplanned admissions. And we are working with stakeholders and consultants on this, and also welcome any input on our expansion of the POW definition. We also need to continue to evaluate progress on sepsis coding due to apparent discrepancies in the level of sepsis care across hospitals. So Next, I'm going to just briefly talk about what is the aggregate revenue at risk under the quality programs. As Diane mentioned in the beginning, Maryland, under our new model, is required to match the amount of risk that CMS has on their national programs. We are required, though, to both match the potential amount at risk, so what's the max amount of penalties, as well as to match or exceed the actual realized amount of penalties and rewards. So what's the actual amount of money or adjustments that result based upon performance. And in order to achieve that, due to the structure of our programs where we have set potential at-risk revenues at higher than the national revenues. So for rate year 18, just to summarize, this is the aggregate, these are the potential at-risk values. These have not changed from rate year 17. For the MHAC program, again, if we are below that statewide minimum improvement target, we would see a max of 3% penalties and 0 rewards. But if we're above the target, those penalties drop to only being a maximum of 1%, and there's the opportunity for up to 1% reward. And then for readmissions and QBR, the maximum penalties are 2% and the maximum rewards are 1%. Also, across all of our quality programs, we have set a maximum penalty guardrail of 3.5% of total hospital revenue. And new for rate year 18, these quality adjustments will be applied to inpatient revenue centers, similar to the approach used by CMS. So last, I'm going to review the monitoring reports that hospitals receive and some other resources. So the HSCRC summary level and case level data files are distributed through a secure site called the CRISP Reporting Services Portal, or the CRS portal. And currently, we've been posting summary reports and case level files for QBR, just for the mortality domain, because that is the only domain that the HSCRC currently calculates. We also post an MHAC workbook, and that's posted monthly based on preliminary and quarterly based on final data. We post monthly a readmission reduction incentive program comparison report, as well as POW reports. And I'm just noting here that new last month, we included a second POW report that provides at a summary level, at the hospital level, what are the specific PQIs that hospitals are having, whereas in the summary report it tells you overall what is your percentage revenue associated with PQIs. This then allows you to look at the detail to see which PQIs are contributing to that overall percent. Now, the reports for readmissions and POW have made on the portal due to rate year 2018 logic changes. We anticipate the POW reports were released last month, and we anticipate being able to release those each month going forward. And the readmission summary level reports are being posted, and the case level detail, both for the base period and year to date for 2016, should be available by the middle of August. So really briefly, I just want to highlight the preliminary data processing timeline. Case mix data is submitted to St. Paul, our data processor, around the 15th of each month. St. Paul then groups that data and sends it to CRISP. CRISP then assigns EIDs and readmission flags. And then reports are produced either by CRISP or the HSCRC and posted to the portal. The goal for these reports, and I know many of you know that this is not always achieved, but our goal is that these reports will be posted by the first week of the following month. and we are working with our contractors to try to improve our timelines on this. However, the timeline is also dependent on timely data submission. In order to be able to get reports out more timely, going forward, we may process incomplete preliminary data. So for instance, if one hospital requests an extension, we may decide that they are simply going to have to submit their data the following month, and we will go ahead and process their data without that hospital. However, depending on the issue, readmissions and POW reports that impact data across hospitals may not be produced. If we process incomplete preliminary data, the reports will indicate that it is incomplete. However, final data will not be processed until all hospitals have submitted accurate data. In order to access reports, if you need access to the portal, you can email support@crisphealth.org. Your request should specify what hospital or hospitals you need access to, as well as the level of access. So do you need access to summary level reports, or do you need access to the case level reports that contain PHI level data? Historically, this access was given to the specific quality program. So if you requested MHAC access, you got just MHAC access. However, moving forward, CRISP is going to grant access based on your level of access. So if you request access to the MHAC summary level reports, you will get access as well to the readmission, POW, and QBR mortality reports. And when people request access, all hospitals have a CRS point of contact. That's generally the CFO or their designee, who is then contacted to confirm and approve access, and both to the reports as well as to what level of access that you need. Questions regarding the contents of reports shouldn't be directed to CRISP. They should be directed to the HSCRC quality email. And I just want to note here that CRISP also has a separate Tableau portal that has interactive reports. So at this time, there's actually two portals, although they are working on enhancements to the portals and to be combining these two. Other resources that we try to make available are, first, calculation sheets that allow hospitals to monitor scores over time or to estimate what their final score might be. And we've provided those for QBR, MHAC, and the RRIP program. I will note that thanks to hospitals and other people getting in touch with us, they have noted that there is an error in the QBR calculation sheet that was distributed with the February rate year 2018 QBR memo, and we are working to correct that, and we'll resend that out as well as post it on our website. The other resources that we're trying to make available is that CRISP is currently assisting us with creating annotated SAS programs and technical documentation for the MHAC, QBR mortality, and POW programs. Currently, the MHAC reports the MHAC SAS programs and technical documentation are posted, and QBR mortality will be posted shortly. So that concludes my discussion of the reporting in the individual programs. I just want to acknowledge the Performance Measurement Workgroup, MHA, the hospitals, and other stakeholders for their work in helping us develop and vet Maryland's performance-based methodologies. We are now going to open it up to a Q&A session. We'll do our best, and please excuse us, we have over 180 some participants. We're going to do our best to ask you to raise your hand, and we will unmute your line, or you can try to type a question. Additional questions you think of, or any questions that we are not able to get to, we ask that you please email the quality mailbox.
So I'm going to read off 5 questions that I think will be helpful in terms of our response to the entire participation audience. So the first question was that we haven't responded to yet is there a plan to give hospitals QBR performance more timely? So calculating a hospital's QBR score can be done using the calculation sheet. However, the data sources come from different places. The mortality data is derived from our case mix data, and in terms of the NHSN safety data, the PCO1 data, and the HCAHPS data, we get that from CMS, and those are updated on a rolling year basis each quarter. So it's very important that hospitals monitor their CMS updates, and earlier in the slides you did see the base period and performance period. If you monitor how you're doing on the CMS measures, it will help you to estimate where you're going to be at the end of the year, and then you can get that same, you can get our data on mortality from, you will get it from HSCRC on a quarterly basis.
And I think also what the person may be getting at is that the data is about 9 months old on the CMS website, and unfortunately those are the timelines that we have to adhere to. We do try to make the mortality data be more current, but we are dependent on the CMS data.
The next question is, it's from James Trumbull. Sorry, the last question was Deanna Stout. So James is asking, as part of its presentation, the General Assembly this past session, there was included a physician MHAC penalty in 2017. A penalty program that is administered by HSCRC, but we are continuing to work both with that advisory council I mentioned earlier and our physician partners in this development process to continue alignment with our hospital program with the physician payments. There are also obviously some legal issues involved that I think that this alignment activity will address. So we have nothing in stone right now about that.
And I'd just like to go back to the question before. I apologize, Shula, we did not see your hand was raised, but our colleague Shula Garovich wanted to point out that hospitals can calculate their scores using the CMS preliminary reports, which are more timely than the 9-month lag that is for public reporting. So again, all hospitals should be receiving these preliminary reports that we do not have access to, but that you have access to and you can use to monitor progress. Thank you, Shula.
The next question is from Curtis Leung. If the majority of readmissions return to the same hospital, wouldn't there still be overlap between the POW and the RRIP measure?
You are correct, and for some hospitals that is the case where the readmission rate may be similar. The RRIP program is going to look at what your case mix adjusted rate is. The POW program is going to look at the percent of revenue for which those readmissions are for those readmissions.
The next question is from, again, Deanna Stout. Does the Medicare match requirement, I think in aggregate at risk, account for the fact that Maryland's an all-payer state and Medicare is only counting revenue for their population, which is the Medicare program?
So as part of this new model, CMS requires that the percent of revenue be on an all-payer basis compared to their Medicare. So believe me, we've raised the issue, but that is what an all-payer state was required to do.
The next question is from Carol McNutt. For readmissions regarding return to the same hospital, does this include readmissions into the same hospital system, or is it hospital-specific only?
It's hospital-specific only.
There's just a question from Eileen Jaskuda. just to clarify when the readmission reports will be available again.
So go ahead and unmute. Julie, we're going to go ahead and unmute you in case you have, if you want to add to the last question and keep you unmuted. We can hear you. Okay, so the readmission reports, the summary level. So in the recent readmission memo that went out, we gave year-to-date through April case mix adjusted rates, and we gave the base period rates for 2013. The comparison report with that data through April will be posted on the website either today or Monday. In addition, we're processing the next month's of data, and we should have the summary level report available, I would hope, by the end of next week through May. But the case level data files for 2013 under the new methodology and for year to date will not be available till the middle of August.
Next question is about the slide set. Will it be posted online? The answer is yes, because it'll be included with the webinar recording and the actual slide deck. And also, you can write into the hscrc.quality@maryland.gov, and if you can request it that way as well.
Yeah, we did try to send it out to people who registered at like by 10 a.m. this morning, but didn't have it for any new registrants.
Okay. What one?
Shule, you have your hand raised. Would you like to make a comment?
Yes, if I can. Can you hear me? Yeah, so I just want to clarify the readmission measure. Readmissions are measuring both the same hospital and other hospital readmissions. So the difference between the RIP and the POW is in the RIP, we are measuring the index hospital. So when you're looking at your readmission rate, it's readmission starting with your own hospital, readmitted to your hospital or another hospital in the state. In the POW, the difference is we're looking at the readmission cases regardless of where they are originating from. So then when you look at your percent readmission in the POW, what you're looking at is readmissions happening at your hospital. And some of them, and in most of the cases, more than 50% is originating from your hospital, but we are also counting readmissions that may have the indexes in another hospital.
Thank you.
So that there is a question from Chiquana Cotton, and the question is, does each organization need to go to HSCRC website to gain access to all the methodology information for calculating QBR, RRIP, et cetera? There are a couple of things you can write into our quality, hscrc.quality@maryland.gov for specific technical questions that you have. We are in the process of updating our website and including all of the technical documentation for each of the quality programs, however. And currently on our website as well, for each commission meeting, there is a public packet from the meetings where each of the programs were approved by the commission, and many of those include technical documentation, but those are difficult to navigate. So I would say best bet is to write in on what you specifically want and to monitor our webpage as well for updates. So the next question is from Jude Alexander, is the RRIP scaled continuously or only at 4 thresholds up and down for attainment and improvement?
It's a continuous scale. We just abbreviated it for purposes of the presentation. And if you use the calculation sheet, you'll be able to see how it calculates that continuous scaling.
And then the next question from Jude as well is there a state threshold for readmissions before attainment or improvement applied under RRIP? I'm not
I'm not sure if I understand the question.
I think they mean like in some of the other programs you have to, like in MHAC, you have to get the 6%.
Okay, yes, no, there is not a statewide target like there is with the MHAC program, where the penalties and the rewards vary based on how the state performs. Okay, I think those are all of our currently typed questions. We can now move, if anybody would like to. Carol. Carol, we're going to unmute you. You've had your hand up. I'm not sure if you, for most of the webinar, so I'm not sure if you have a question now or.
Okay, Carol, you should be unmuted now.
Maybe she stepped away.
She also may be muted on her end.
I was muted, but I didn't have a question. I don't know why it was flagged.
That's okay, Carol.
Thank you.
It was a good sound test.
Let's see who else.
Okay, we're not seeing any other raised hands. Now is your time to speak up. Okay. Well, this is great. I am Jude Alexander. Let's unmute you. You have a follow-up question? Jude, you've been unmuted.
Yes, hi, thanks. Great presentation. I was just wondering if individual groups can access or get from you their all-cause, total hospital, severity-adjusted readmission rate for any given performance year. Right now the data is at the hospital level, but can you parcel it out by group, such as hospitals?
Yeah, so currently we just have it at the hospital level, and I'm not sure that in our case mix data we have the ability to do the subgroup analysis. Is that correct? Is she still unmuted?
Yes, she's unmuted. Oh, no, she's not. She muted herself.
All right. Yeah, so we aren't, I know, Jude, I think you're interested in specific how physician groups within the hospitals are performing. Is that correct?
Yes.
Yeah, I would encourage you, I think Claudine Williams, who is in charge of our data collection, I believe there were some additions to this next fiscal year data looking at like a principal provider, and maybe something could be used for that in the future. But right now, we can only look at it at the hospital level.
Well, I think if hospitals use their case level data and match with their medical record and medical record number, they could parse it out themselves.
This is Shirley. Sorry, I was muted. I couldn't speak earlier. There is an ongoing work at the CRISP to structure some of these reports based on the physician groups. So obviously, as Allison and Diane mentioned, it kind of depends on the accuracy of the physician identifiers in our data set. So that's one stream of work that CRISP is working. The other one is, the HIE has the panels of patients that the physicians can submit, the primary care physicians and others. And they are also working on those types of reports where the panel will be defined for certain patients, and CRISP is going to produce a readmission report regardless of which hospital those are admitted or readmitted. So they are both in the works, and it will be great if we can connect you with the CRISP folks so you can maybe help with the design of some of those reports. Can I get the volunteer?
Sure.
Yeah.
We're already talking with them.
Oh, great. Great.
Okay, we have a couple other people that have questions.
We'll unmute Curtis Leung, and I apologize if I'm not pronouncing your name correctly.
Oh, they haven't entered. He hasn't entered his call.
Oh, Curtis, your hand's up, but you have a microphone that's muted, so if you can type your question, may be most expedient if you still have a question, because I know you had some earlier that you had typed in.
So next we'll unmute Tracy Davidson. Tracy, we should be able to hear you now.
Yeah, can you hear me?
Yes.
I just want to respond to Jude's question about pulling out per hospice group. I can certainly pull his raw rate. I do not have the ability to do his risk-adjusted rate right now. So, I mean, and I do provide that raw rate on a continual basis. I just
So you might be able to use the normative values that we provide at the APR DRG severity of illness level to calculate a case mix adjusted rate at that lower level, but you would have to use those normative values.
Okay.
You know what? I'll reach out to Claudine Williams. I'm sure we can figure out a way between Crisp and Claudine to work this out.
Yeah, and I can help with the case mix adjustment if needed. Okay.
Great.
Thanks.
All right. Amy Duschendorf, we're going to unmute you now. You are unmuted.
Hi, Amy.
Actually, this is Diane Lepley, and I'm filling in for Amy today. I just had a quick question about the RRIP and the rate year 18 methodology. Are you applying that to both the base year as well as the performance year?
The changes in the measurement, like the change in the transfer definition, etc.?
Exactly.
Yes, they will be applied to both the calendar year 13 base period. So, you know, the base period has not changed from fiscal year 17 to 18. And we will be putting out, and we've already put out the base period rates under the new methodology, but we will be providing a case level file as well that matches that methodology. But any of the measure, we are going to continue to compare on the same measure for the base and the performance period.
Okay, terrific, thank you.
Thank you.
There is a question from Leslie Hack, and that she has written, and she's asking for clarification or information about the apparent discrepancies in the levels of sepsis cases across hospitals. And we're currently in the analyzing the issue. We do see some shifts, for instance, in pneumonia, where it may be lower, or urosepsis, and there may be higher sepsis rates. So we're in the midst of actually analyzing that data right now, and that is one potential area. I think you're referencing this question from the POW.
So for POW for this year, we did consider expanding the POW definition to include any admissions for sepsis. However, given discrepancies across hospitals and other things, we decided we weren't able to do that this year, and that we needed to continue to understand these differences. So next we have Curtis's question. For POW, would we be able to identify readmissions received by our hospital but are attributed to another hospital? And the answer is yes, and there is a case level file that will tell you which the originating hospital is. And if the, yes. Okay. Scroll to see. Curtis, if you have a follow-up question, please feel free to type it, or and I'd just like to point out there are some people who've hit the question option. If you have a question, please hit the raise your hand option. Tracy, it looks like you have another question, so I'm going to unmute you.
Yeah, so what would I do? I could just take their denominator number that I come up with, and for each of these APR, DRG, severity of illness, and just multiply it by the norm, right? Which would give their expected for that APR, DRG?
Correct.
Okay.
And we can work through that if you need assistance.
Okay, thanks.
Are there any other questions? We have a question from Jude about who qualifies as a palliative care case. We use ICD 9 and 10 codes. I believe the specific codes were in the memo that we sent out, but if you contact the quality box, I'd be happy to give you them. I don't know them off the top of my head, but it is based on ICD codes.
Yeah, and I just wanted to mention, since it's brought up, we are going to be looking at that code. Our impressions are that there is not a clear definition of when you would put the palliative cases, and we see incrementally the codes being used more widely than we had in the base period. So we think some of our improvement is a result of the palliative code increases in the data. So for this year, actually in very near future, we'll be looking at that code and evaluate whether it's still appropriate to exclude those cases from the quality programs.
Thank you, Shule. Tracy, you have another question.
Yeah, and for the palliative care codes, there's specific parameters that have to be met for it to even be coded. You can't just say, like a physician can't just say, well, they're going to be palliative care, and then it's coded that way. There's 3 specific criteria that have to be met before the coding can ever occur.
Right. I think what Shule may be referring to is we've seen increases in that coding over time, so that's why we are looking at it.
Okay.
Right, and I think I'm not a coder, so we will appreciate your help in identifying, but we've been told that the comfort care definition is not that clear in certain cases. And when you look at your mortality scores, for example, in the base period, we had about 20% of the cases coded as palliative care. Now it's more than 50% of those cases coded as palliative care. So we hope that it improved the palliative care in the hospitals, and we hope that this is a correct level of coding. But at the same time, given the trend in the data, we will be evaluating those specific codes and see what the impact is on the quality programs.
Okay. Well, I could speak specifically for us. We might have met like 2 of the parameters, but the last parameter was met but not documented. Mm-hmm. So if it's not documented in the record, we couldn't use the 3rd parameter. So what we did was we did provide education that you can't. I think usually what it was the conversation with the family did not get documented, even though it occurred. The nurse might have documented it, but the physician did not. If the physician didn't document it, then the coder could not code the palliative care. So what we did was we educated the physicians that when you do have this conversation, you have to document that you spoke to the family. Mm-hmm. That's one of the ones. You have to have a conversation with the family. You have to write the order for comfort care, and you also have to reduce the care that you're giving. So those daily 3-4 times a day labs, the aggressive treatment regimens need to stop, and it needs to switch to comfort measures, oxygen, pain medications, things like that.
Yep, they all make sense. Thank you for the help.
So there is a question from Amy's line, and I believe that was Diane. Do you have an update on when Maryland hospitals may have access to CMMI limited data sets for calendar 13 to 15?
I'll take that if you don't mind, Diane.
Please.
So the limited data sets, there is a memo went out, I believe, the beginning of this week to the CFOs of each hospital. So for those who are not familiar with it, HSCRC worked out an agreement with CMS to get the limited Medicare data sets, both Part A and Part B claims for all Maryland residents. It won't have any names or identifiers, but it is at the claim level to help you to understand the trends and then analyze the data for planning and analysis purposes, not for care coordination. So the memo outlines the way that you could request the data. Hospitals have to request data to CMS, and CRSP is arranging the process. So you need to send the DOA request to CRISP, and CRISP is going to compile and send it to CMS so we can get the data quicker than regular ResDAC policies. So I think we are hoping to send the first round of requests, hopefully within 10 days. So if you could work with your folks to fill out the data request forms as quickly as possible and send to Laura, who is actually presented the readmission one. She's in charge of that. We are hoping we'll send the request, and we are promised that the CMS is going to turn around the data hopefully within 10 days or so. So it's a high priority for us, and we are hoping that working with you, we can get those quickly and then have the data at the hospitals or in the CRISP environment as soon as possible.
So it looks like we've come to the end of the webinar time, and I do see an attrition here of about 25% of attendees having dropped off. So I think we will conclude the webinar. We encourage participants, if you have additional questions, to send them to hscrc.quality@maryland.gov. The webinar will be posted along with the slides on our website.
Along with the recording of the webinar.
Exactly. And our next performance measurement workgroup meeting, if anyone has interest in monitoring or listening and providing input, is Friday, September 16th from 9:30 to noon. And we do post information on our website routinely about those meetings.
Thank you all. We appreciate everybody's attendance, and please do contact our quality mailbox with additional questions. And we look forward to working with all of you to continue to improve the quality of care that Maryland hospitals deliver.